right, so I am Les Whalen. Welcome to USD Stanford School of Medicine and the Joint Mayo and USD Pediatric Grand Rounds. This presentation is part of our 2022 Pediatric Research and Scholarship Day, so thank you all for taking part in this. This week we're delighted to have Dr. Brophy. He's a pediatric nephrologist professor and William E. Islander, Chair of Pediatrics at the University of Rochester Medical Center in Rochester, New York. We've had to clarify that a couple of times today. Yeah, the other Rochester. He's joining us as the Sanford Mayo Denny Sanford Distinguished Lecturer. The visiting professorship is sponsored by T. Denny Sanford Endowment, Pediatric Collaborative Research Fund between Mayo Clinic and Sanford Health. Dr. Brophy received his Bachelor of Science, Bachelor of Arts, and his medical degree from the University of Regina in Saskatchewan, Canada. He has his sorry socks on today, so if you have any question that he's Canadian. He went on to complete pediatric residency at the University of Manitoba, Winnipeg, followed by pediatric nephrology and research fellowship at the University of Michigan in Ann Arbor. He went on to a very successful tenured academic career at the University of Iowa, where he helped shape the academic careers of many of our colleagues who came there. At the University of Iowa, he grew a robust pediatric nephrology division and led both basic and translational research programs. He trained excellent residents and fellows, including our own Dr. Ty. His clinical excellence, please don't hold it against him. His clinical excellence, dedication to research, teaching, and mentoring propelled him to the rank of professor. In 2014, he became the Jean E. Robillard Chair of Pediatric Nephrology. During his tenure, Dr. Brophy also completed a master's in healthcare delivery sciences, and with this, his career shifted to focus on socioeconomic determinants of health and innovation to overcome disparities through improved access to pediatric health. He advanced this goal as the Assistant Vice President of eHealth and Innovation and the co-CEO at the University of Iowa Health System. In 2017, he was wooed away and recruited to the University of Rochester as the Chair of Pediatrics and Physician-in-Chief and CEO of the Golisano Children's Hospital. All in all, Dr. Brophy is an acclaimed leader in the field of molecular genetics, of renal development and anomalies, a neonatal pediatric critical care nephrologist, a acute kidney injury prevention and treatment, and healthcare delivery across the life source is something else. His service to the profession, honors, and awards are too numerous to list, but his internationally renowned work includes over 150 published manuscripts, 19 book chapters, and numerous lectures that have helped countless families affected by kidney disease. We're fortunate to have Pat here today. Please join me in welcoming him.
Thank you for kind of an overwhelming introduction. Sometimes it doesn't seem like you get all that stuff done, but I've been super lucky in my career. I want to say thank you to you all for being here. I want to say special thanks to Michelle, who has been a friend and colleague for quite a few years now, and some of the folks I got to work with and take part in their training who are around here. So when I moved to Rochester, I became probably more knowledgeable about poverty than I ever wanted to. And Rochester, New York is the 5th poorest city in the country. And with that, we have amazing challenges that we have to deal with on a regular basis. So just to start off with, I truly believe that the soul of our country lies in how we take care of our kids. And after what happened in Texas a couple of days ago, it's devastating. We had Buffalo last week. We have to do something different, right? Kids are not taught to hate. Kids learn to hate. They're not born with hatred. Right? We have to figure out a better way to do things. Our motto, mission at Golisano Children's is helping every child reach their fullest potential. So I just want you to think about this. Daniel Prude was a Black man in Rochester. They had video of him getting murdered on the street by police officers. That was at where I live. So if that doesn't affect you, there's a real problem, right? This happened with George Floyd. I had one of my fellows, a Black physician, and she called me. She was terrified to come out of her apartment. She lived downtown. And there were people that were, rioting around her. So it's terrifying. And for me, that was really probably the first time I heard that in somebody's voice, how horrible these things are. So just to look at health inequities across, and I'm just going to start off with a little bit of data from where I live right now. So if you look at the overall infant mortality, right, and that really reflects our status of a community, quality health care, access to care, prenatal care, you can see, and over the course of a few years here in Rochester, Monroe County, where our county is, the significant proportion of Black and brown kids that actually have a higher mortality rate. Why is that? What about early prenatal care? Reversed, right? Caucasians have the highest access to good prenatal quality care. Babies born with low birth weights. This is in our county as of 2017. You can see, again, great disparity comes in. And all of these, right, really have been unmasked and even perpetuated through COVID. So what I want to talk about today is disparities. And I feel disparities and socioeconomic disparities particularly are really part of the new morbidity in healthcare, because we've kind of changed a little bit, and I'm going to talk about that. So here's a question for you. If I gave you, or if you gave me $1 today, and I gave you $11 next week, that'd be a pretty good deal, right? I want you to think about that. I'm going to ask the question why I said that when I go through my talk here. So we're going to talk a little bit about lifespan and, across the human condition from birth to grave, right? And why looking at that as a holistic potential, particularly in the realm of health. And it's not just health care, it's health. Healthcare is a very tiny portion of what we do on a day-to-day basis, right? And developing a return on our investment. Because healthcare is a business, whether we like it or not. It's a big business. And so in order to make things functional, you do have to bring in some dollars. So we have to figure out how to do that in a fiscally responsible way that provides the best care, the easiest care that we can get to. I talk about the 5 Ds of pediatrics, and then investing early. And I'm going to tell you a little bit about the mission that we came up with at Golisano Children's Hospital. So disparities really, they've been around. And if you actually do a literature search on this, there's not very much information recently in this area. You would think there would be a lot, but there's not really. And there was a coalition, a conference in 2008 that looked at the agenda to develop a research agenda towards, getting in and drilling down on disparities. And the focus really was on multiple prongs, including environmental factors, biologic factors, socioeconomic, psychosocial, and then developing metrics for that, what kind of interventions we can do. So what is a disparity? We think we know, but they're not really simply difference, but an inequitable difference, all right? That is potentially systemic and avoidable. And that's the key, right? These are potentially avoidable. Who has the health disparity? So most of the time, these things are set up based on race and ethnicity, socioeconomic status, generational, or geography, right? Rural versus urban. And there's a real complex interaction between the two. So how do you actually drill down into each of these? What disparity are we talking about? Health outcomes, health care. So health disparities research really should involve consideration of life opportunities that people have, life chances, quality of life, that's an important part of it, psychosocial and socioeconomic perspectives, as well as more traditional attention to health status, not how healthy you are, but the health status of our community and how well we as providers can give you care. So levels we see disparities produced, right? And these are really across the spectrum. Environmental, right? So I live in Rochester. Rochester had Kodak there for many years. Well, it turns out Kodak was notoriously bad at having asbestos in all of their buildings. And so there's a big population of people that have developed lung cancer and mesothelioma from that. But nobody really knew about it. And so that environmental impact, you can start to see pockets of people developing these cancers. So really important, right? But you can't necessarily see it in the air, so it doesn't happen. Right? Can't see it, it's not there. And then there's a couple areas that we can really develop on. And one of them is access to healthcare and quality of healthcare. More is not always better, right? Good care, have access. So I thought this was a really good cartoon. It actually kind of takes into account multiple different inner working processes here when we actually think about health inequities. So environmental stressors, your home, your neighborhood, people smoke around you, things like that. Major life events. Right? We all have had areas and times in our lives where there's been some kind of traumatic event. Probably, if you haven't had one, you're lucky. Trauma and abuse. And so that is not uncommon, certainly, in our lower socioeconomic groups. Individual differences. So the genetics, right? How is what are your epigenetic tags like? What is it generational? Behavioral, fight or flight response. What do we do? How do we take care of ourselves? Drink, smoke, exercise, things like that. And then physiologic responses. And that really gives us the phenotype. So within healthcare specifically, we see disparities that can rise from different areas. So patients, right? Health literacy, that's a big one. We talked about that this morning. Right? The expectation that people will have a knowledge of what you're talking about is wrong, inherently wrong, because most people don't. Kind of assume they do, and we forget when we get, especially with our medical language. Adherence, have to take your meds. Big challenge for all of us. Patient preferences. Providers, so poor discrimination, or poor communication and discrimination. Implicit bias comes through in this, particularly when you're looking after children of color. And I have a woman that I do grand rounds with periodically. She's a Black woman who had 2 children in our NICU. She has informed us on how different care was for her as a Black woman compared to white. And it's really troubling. Talk to her. And it's how she told me she would have to get up at 5 a.m. to make sure she was dressed to the nines before she walked into that NICU, because there was judgment already handed down, and there was other Black parents there too. And she actually looked at her chart, and there was comments on the chart of how well she looked, and she's going to be good. So I mean, those are things we all do. Need to do it most of the time. I think it's just part of our culture, part of the way we're raised. But knowing allows you to start to change that. This is the big one. I think the biggest challenge we have is health system factors. So in Canada, obviously, it's a universal health care. So a lot of these issues go away because you do have access. The problem there is timely access because they don't have enough providers. This is obviously a big country for immigration, and Rochester in particular is a very diverse city. And we really strive to actually have our docs, nurses, EVS staff, as many people reflect their community. And this mom that I worked with, one of our residents who's actually going to WashU to become a pulmonologist, hoping she'll come back, but she's a Black physician. And I got a picture of this mom. Her daughter was in because Terrace, who's our resident, was in there. And the little girl looked up at her and said, "Hey, doctor." That means something. So I like to look at this across the lifespan. What does early experience matter? Well, if you think about it, our brain triples in size for the first couple of years of life. And so that first 1,000 days of life becomes the most important part of our development next to puberty. All the things that happen, all the plasticity that happens is there. That's the time when we are most at risk. a lot of things because we don't have voice. We are open to what our environment is, right? I thought this was a pretty cool. This is from Harvard um, Center for Developing Child. And if you look at this, more than 1 million new synapses created each second. Very powerful. Why do we care about this? Well, it turns out perinatal outcomes in early childhood development really impact on how people go on to develop disease. And again, how adults actually demonstrate their phenotype, get older. So I'll give you a kidney example. There was a study in the Scandinavian countries, and they looked at kidney development and people that had any kind of traumatic issues at birth that impacted their kidneys. So it could be premature birth, medication, whatever. And as those folks aged and their kidney function started to decline, they actually had earlier onset chronic kidney disease. Of course, that cost the system a lot of money. So if you think about this, particularly in, let's say, a case of a woman with diabetes who's pregnant, she has a child and her diabetes is uncontrolled, right? That child is born usually quite large, right? And they often have cardiac issues. They often have. And so think about if you could actually mitigate that, prevent that from happening. Not only do you actually save dollars in the first place, it's much better for mom and, but you likely prevent consequences of that as the patient's age. So it's a double whammy. You don't really think about that. Cardiac disease, we treat all the time. We'll walk in, well, how did we get there? It's expensive. So if you look at the links between childhood stressors and adult health, this was a study that was done at Kaiser Permanente, 17,000 people surveyed on history of abuse, neglect, family dysfunction, and then looked at their current behavior and health status. And as the number of adverse childhood events increased, the risk for poor health outcomes. And that intuitively makes sense, but we really didn't look at it. We started looking at this. And it tends to be a little bit higher in women. Right? And I think there's a lot of different reasons that for that. Generally, women tend to be at higher risk, at least, of sexual abuse or early childhood abuse, maybe than boys do. So there's a lot of factors. What about overall well-being? You look at this from a national perspective, right? So dimensions are across the top. They're material well-being, health and safety, educational, behaviors and risks, and subjective well-being. And look at where the United States, right? Now we're the richest country in the world, right? Do you guys agree? We have the best healthcare in the world, right? We spend the most on it. Best? Why is that? I mean, if I'm a business person and I invest in something, I want return on my investment and I want some quality. What are we doing that we can improve this list? And again, infant mortality. This is still true today. There's been some improvements, but it's still the same graphs that we see. And I don't want to depress everybody, but these are issues that we have to deal with every day. You can see pretty clearly Black and First Nations or Indigenous peoples have higher rates of mortality. Right. Child poverty. Look at where we're at. So these are all pretty modern, pretty wealthy countries in general. And if you look at child poverty in the richest country in the world, we're doing terrible. About by race, 2010. If you look at our national average, 22% in this country are considered. That's a heck of a lot. In any country. Out of those, though, you see the big difference. Right? Our Black population, 8%. Our Indigenous population, 35%. Hispanic population, 32%. You really start to see what a what an issue we have as a country, what we need. So how do we approach these things? Well, this was developed through the IOM, Committee on Evaluation of Children's Health, and it really is a paradigm that's set up to focus on advocacy policy, services, and how the interaction comes together with social, environmental determinants, biology, behavior, and a physical environment. So we can't separate these out. And we do this all the time in healthcare, right? That's healthcare. So our focus has been to really engage our community. And we actually have regular meetings now with the school board. And if you think about how government sets themselves up, education here, health over here, they never talk, right? They need to, because of this, because it's such a complex interaction. We really need to figure this out. So what are the 5 Ds of pediatric disparity? Demographic patterns, developmental change, we're moving targets, dependency, obviously, most of our kids are dependent on us, differential epidemiology, and dollars, cost of care. So, we started this a few years ago when Obama was in power, focusing on moving towards value-based medicine. And, in our current environment, obviously, it stalled a little bit, and I think we're still evolving this. But how do we actually take all of the developments that we've had and the things that we've done? I mean, how many people here have smartphones? Pretty much everybody, right? So as you think about it, you have more power, more computing power in that phone than they did in the Apollo mission that went to the moon. And that's amazing, right? Instantaneous. So we ought to be able to use that or use those technologies to deliver better healthcare. So how do we develop that framework as we go forward? Right? Well, we know healthcare it's still in transition. I think last century was really adding light or years to people's lives. This century really should be adding life to people's years. So quality, really focusing. Right? So outcomes, again, overall rankings, healthcare. Here we are, expenditures. Right? We spend the most money, we ought to be the best. And turns out we're not. So here's a question for you. How would you change healthcare if I found or gave you $750 billion? Why? Why would I ask that question? That's how much we waste. Minimum. If you look at this, this has nothing to do with making anybody healthy. It has nothing to do with actually improving our quality of life. It has everything to do with excessive administration costs, fraud, that's a big part of this, unnecessary services. Now, we have a perverse system. I'll give you an example of that. So if I do a CT scan on somebody and I send them, and I'm a primary care doc, and I send them to the hospital, they don't want my CT scan. They're going to get their own CT scan. So it's duplicate services. That happens all the time because you make a lot of money when you do imaging. So the system is set up to drive that as opposed to value-based, where you're trying to keep people out of the hospital. And so what about creating value in healthcare? Well, I love basic science, and I think I wouldn't be here if it wasn't for research. And the problem is it's super expensive to do research, right? I always say, people say, well, research is expensive, and I go, try disease. It's a lot more expensive than research. So, if you think about this, one of the things when I started to look into healthcare delivery sciences is it's very cost effective in terms of research, because you can actually go in and make changes on our day-to-day operational stuff, or implementing early opportunities for monitoring diabetes. And I'll give you an example of this. I use that example of pregnant moms because when I was in Iowa, we worked with our OBGYN colleagues. And we were able to actually identify a group of women that had diabetes, right? And they were pregnant. And so we went and we looked at the structure of how they, kept track of all the people, all the women that were pregnant. And they had 1 or 2 nurses calling every single one to try and make sure that their glucose were under control. and they had a hard time with it. And it turned out about 80%, 85% of all the women that were following were fine. But it was that 15% that really needed the help. So we got them to actually do home-based monitoring, and we checked their sugars. And over the course of their pregnancies, it was that small cadre of women who had much better control, and we did not see the kids get sent to the NICU, and we still don't know what we're going to benefit down the line from. But what was really cool is not only did it help the parents or the patients out, and the moms and the babies, but it actually helped us out because we spent less money on staffing those folks, right? Because we were able to target using technology a specific group that really could benefit. So obviously, health development occurs across our lifespan, and you can see it represented by different trajectories. And again, there's critical times when we develop and when we become, go from our teenage years to our adult years, we see a lot of change. And so if you think about it, and I thought this was a pretty good cartoon as well. So how is our health status determined? And a lot of people say it's all in the genes. I think there's a lot of it in the genes, but it's certainly not all. And so, if you think about it, behavior is really a big part of it, how we do things. So our exposure, prenatal smoking, still an issue. Certainly in upstate New York, it's an issue. We still got people smoking. Child abuse, childhood socioeconomic issues affecting our epigenome, right? So another example of this, I have a very good friend, and she's a physician in Calgary, Alberta. She spent a lot of time in the high Arctic and adopted an Inuit baby when they were born. The Inuit community has been plagued by a lot of alcoholism, a lot of behavioral issues. And she said, I was convinced that when I took this little baby out of that environment, it would be fine. It's got the same issues that his peers. There's got to be something to that, right? So it's this generational. When your DNA starts to get changed by epigenetics, that's a really interesting hypothesis. Obviously, our output, our genetic output, exposes us from biochemical and biophysical pathways, depending on what we do in terms of our exposures. That gives us our phenotype. So second decade, right? You see this school failure, teenage pregnancy, criminality, substance abuse, anxiety disorders. What's happening in our community now? It's just getting worse every time. I don't even want to watch the news anymore, right? Because we hear about this every day. Anxiety disorders. Kids have anxiety disorders. I'm just stunned by it. 40% of all of our visits at our institution are for healthcare or mental health related issues. When I was training, it was all infectious disease. So it's a real challenge. But what happens? You see people develop obesity, elevated blood pressure, depression. That manifests later on in things like diabetes, renal disease, arthritis, coronary artery disease. And then premature aging, memory loss. And as we get better at taking care of people, we see this more and more common. So I like this cartoon because it really kind of gives me an idea where we're at right now. And I think we're just starting to get past this stage. But we still have a huge problem with food in this country, right? And we were talking earlier today, food insecurity is a huge issue for families and kids, particularly in the rural settings. If you go to a lot of places, sometimes all they have is a store attached to a gas station. And if you're lucky, you might have a Family Dollar or something like that. And that's food, but it's not nutritious food. So this is really, important. And these are self-inflicted wounds that we have. We can do better. So not optimizing healthy development, right? If we don't address the trajectory and the factors that shape health over the course of a lifespan, we see what happens, right? We lose people along the way. People show up at our emergency departments rather than seeing a primary care physician or a practitioner because they can't afford it. So they go to the emergency department when they're sick as heck. So how do we actually change this, right? And current practice, that's most of the time we do okay, I think, in pediatrics. But think about the opportunities that we have to improve this. Think about how much we can do, how better we can do with taking care of our kids. So I like this because this is it talks about risk reduction and other opportunities for us to um, change risk factors. So smoking, early drinking, early sexual development, things like that. And then if you look at health promotion strategies, we have a pretty strong anti-smoking program in New York State. But what happens when the budget gets a little tight? Cut away, right? We don't need that. People know they shouldn't smoke. I'm not sure about it. So, I think we rob Peter to pay Paul sometimes. And, as we move forward with this, if you think about it, when people get into their 60s, right, that's when you start to see a lot of the issues happen with chronic disease development. So if we're able to actually reduce our risk factors and improve our health promotions, right, we ought to be able to change where people become symptomatic, move it out 20 years. And so that's adding life to the years we have. How do we do that? So if you think about, business value is quality over cost, delivery over time. Well, I think in healthcare, we got to think about it a little different. And this is really what I wanted to talk a little bit about is health development and investment. So remember when I told you, if I gave me $1 today, I give you 11 next week, that's a pretty good deal, right? So for every dollar we invest in early childhood, we get 11 back. Now, when I talk business meetings, sometimes I give a lot of the business folks that information because they kind of get that. It's a stock market. Everybody be happy about that. The problem is instant gratification doesn't come soon enough. So when we invest in early development for kids and babies and moms, right, that dividend is not paid out for a long time. So people don't see it. So it's very challenging when you're talking to folks about trying to get them to invest in early childhood development. I have to say I'm pretty happy with my senior leadership team right now because we are actually building a mother-baby clinic in downtown Rochester, which will have a pediatric urgent care, mental health urgent care, access to all the specialties, a good primary care group. And it's easy to get to. When I got to Rochester, 50% of my Medicaid patients didn't show up for their clinical appointments. Why? No transportation. When they did get transportation, they'd have to sit downtown in the bus transfer for like an hour and a half. Someone would lose their job. So it's just, you got to go where the patients are. What you guys have done here with setting up the clinics, I got a really nice tour today, by the way, thank you. But the proximal stuff, it really is about the patient. And our buildings are old, so they're spread apart. So we're really trying to get to what you guys are doing here. So the challenge here, of course, is changing how we think, right? Culture is very difficult to change. So how do we approach it? Well, one of the things we're doing is we've actually developed a health lab, and we have a pediatric section within the health lab at the University of Rochester. And so when I was in Iowa, we developed the Signal Center for Health Innovation, where we set up a network across Iowa with telemedicine. UIE Care was something we deployed. It was one of the first telemedicine platforms out there. We actually had a Spanish version of it too. It was really cool. So we did a lot of things, and not everything works, but that's okay. If you do it, fails, you get out. Problem in medicine, people don't want to hear that they failed. But if you don't fail, you're not actually pushing the limit. You're not doing the right thing. So how do we actually set this up? So we have now developed I call it a digital therapeutics residency track for our students. And we've attracted a couple of engineers who went back into medicine. And they are just amazing in terms of their knowledge base on informatics. And so we're actually working with the health lab. We carved out this pediatric space. Now we have our students coming in there. And what we're doing is we're actually interrogating our health records to look at areas where we can reduce unnecessary testing, reduce the cost of care, improve access through artificial intelligence and some other things. We use a lot of virtual reality, and we actually just signed a contract and have a new little robot called Moxie, and it's a child life robot. And it actually sits with the kids and talks to the kids. It's fascinating. And we also have the Strong Museum for Children in Rochester, and we're able to actually operationalize it for kids in the hospital. So it's really cool. They can actually go around and look at the museum when they're in the hospital. So there's a lot of things we could do, and those are, kind of toys a little bit. Where you get really into the meat of this is when you start to see cardiac care. So there's implantable devices that you can monitor cardiac status on somebody who's got heart failure. So before they actually show up in the emergency department, right, you can actually change their medication. You can change the way you approach it. Right? Again, no visit to the ED saves cost, but it's much better for the patient if they have continuity of care. And I know some of you have Apple Watches, and of course, Apple's recording everything that you do every day with Google. And so, the next few years, you're going to see probably Amazon, Google, Apple, a bunch of the other companies. You're going to see healthcare fundamentally change in this country because they're going to start cutting out the middle person, the insurance companies, right? And they're going to go right for their people. And you're starting to see this develop already. Atul Gawande is actually medical director for Warren Buffett, I think it was Apple, and Bezos, I think, all in there to actually reduce their healthcare costs. That's what it's about. It's about reducing their costs. But because they have the technology, they're able to actually deliver better care. Now, our bigger challenges is regulations. So when I was in Iowa, I used to talk with the Republicans, and they would say, well, this is too expensive. Well, you want to stimulate business, small communities, you have to get people there. To get people there, you have to have a foundational healthcare. I go, well, that's right. And I go, well, if you guys help reduce the regulatory environment, we could get that. Okay, that's great. And then I talk to the Democrats, and I'd say, we really need to get healthcare out to the rural population. Don't you think that's an important part of your platform? Better healthcare access for all. Well, yeah. I said, well, if you reduce the regulatory environment, we can get you there. So two different arguments for the same goal, but there's got to be a stake in these guys. And so, for us, us collectively, I think the future is really shaped by how we engage technology in this space. A lot of issues, I know, patient privacy, a lot of things like that. But if you think about it, most people, not all, but most people don't mind sharing their data, as we do it every day. We don't give people permission for that. We do it every day. So I think there's a real opportunity for us to utilize things like e-medicine, e-consults. We started that when I was at Iowa. We actually are doing it now in Peds in Rochester. We've developed an in-school telehealth system for our kids in the inner city schools who have asthma so that we can actually intervene on site with a school nurse before the kids get super sick. And, I've got a few colleagues and a few of my faculty that have grants in this space, and they're just doing fabulous, amazing work. One of the things we're going to put down in our downtown clinic is a new allergy program that will allow us to really look at their environmental factors. So we're pretty excited about that. Anyways, I think we have to be innovative, right? We don't have a choice. Every time we turn around, certainly in my job anyways, well, that's a lot of money. How do we do that? How do we actually bring it together, make a meaningful case, and then show value based on it? I think it's through technology. It's through interrogating our electronic medical record. It's through utilizing our smartphones that most of us have. And the challenge is for us to adapt, change that, right, as we are providers. How long does it take for medicine to adapt changes, roughly? About 15 years. I mean, we still use a fax machine, right? We're the only industry that uses a fax machine. That thing ought to be gone. I hate those things. But it's true. But what happened 3 years ago? COVID, right? On a dime, people had to switch. You didn't have a choice, right? You wanted to survive, you had to. And then all of a sudden we realized, hey, we can change how we do stuff. So for me, space is a big issue. Well, half of my staff and half of my faculty work from home now. I think it's wonderful. I think it gives people opportunities. Not everybody likes that, so they come in, that's great. But working from home, we have not seen any reduction in our productivity. As a matter of fact, I've seen more engagement now because our families, and we tend to have young faculty that have young families, got to get them to school, particularly when COVID was, people were going crazy, and they can connect. They don't have to be there. So for me, that really sort of justified my thinking for the past 10 years about what we ought to be doing and focused on technology and how we can deliver better care, actually reduce disparities by having access to better health care. So our 5-year strategic plan, we actually got everybody, all the stakeholders from across the community, foundations. We got some of the poverty groups that really focused on that, everybody. And we sat down and came up with this mission. So do everything in our power to help every child reach their fullest potential. We have 7 patient pillars, and you can see one of them is digital health. We also actually appointed Vice Chair of Diversity and Development before all the racial disharmony hit in this country. So we were actually out doing implicit bias training first. But what's really happened is that digital health has become a theme through every single one of these. And as we look at it and get more granular on those data, and hopefully one of my faculty members is going to take on this role, but I'm actually hoping to start a division of digital health with Pediatric. And she is very smart, she has a business degree, and she understands the analytics end. So I'm really hopeful she'll be able to get in, really start digging through our numbers and show us how we can do better with our population as a whole, but particularly better with our kids that are at risk. And it's really interesting. I always like kind of ending with this slide. This really, I think, makes a lot of sense, right? So any point of this, right, vision, skills, incentives, resources, action plan, get changed. So if you block out any of those, no problems. How many times have you seen a strategic plan get developed and then put on a shelf? Never see it again. What happened? Oh, I don't really know. We did all this work and then we didn't follow it up. So we took our strategic plan, we made it a living document. We actually applied quality improvement principles to it. So PDS A cycle. And we do quarterly meetings and we review metrics that we set. We can move resources from one area to another, depending on what kind of momentum we have in that space. And it has been well received by our faculty because they're engaged. We have different pillar leaders in each space. We actually published a paper on this because we couldn't find any literature that actually looked at a strategic plan using quality improvement strategies to assess its effectiveness. So it's been really a learning experience for me, but it's been fabulous to really kind of get all of the new leaders that we're seeing in our community, in our physician community, come out. And one thing we've done in Rochester is when I got there was about 10% female leadership in a department that was predominantly women. Now we have 70% of our vice chairs are women, 55% of our division directors are women, 40% of our full professors are women, and we developed pay equity. So it's 50th percentile for our female faculty, 49th percentile for our. And that's intentional. You have to be intentional. Otherwise, they just drift away. So this is the picture I was talking about. And I have permission from her mom and from Terrace to show you this. I'm happy to take any questions. Thanks. Definitely not basic science, right? I think for me, part of the interest is to really be able to do systems change, to affect it on a different level. Part of that, you have to become more of a politician, which I'm not always good at, but a big part of it. We all have to own this if we want to change it. Yeah. Yeah. Oh, yeah. Yeah. So technology, no, but I've seen a couple of, I'm not going to say no, but I haven't seen anything to come across that I would say is super exciting. What I have seen, though, is development of some new approaches to substance abuse. So rather than take somebody and throw them in jail or whatever, or even when they're, get caught with DUIs, and there tends to be people that have multiple issues, and you often see kids that are exposed to that and a lot of issues. They actually have really started to move away from criminalizing it, pushing them more right into therapy or treatment. That's going to take a while, but I think that's absolutely the way to go. We do have some good places where we have interventions in Rochester. We have a couple of houses, Restore Mission and a couple other ones, where mothers and children can go to get help. But it's still, it's still very challenging. We have something called the Bavona Health Center, the Bavona Center for Abused Children, and so we staff it. It's gut wrenching when you go in there and you hear about these things. So trying to figure out how to get at it, I think you can piecemeal it, or you can actually go after the root cause. And the root cause, poverty. Root cause is challenge. The root cause is not having this, right? 2,000 kids in Rochester are homeless. Homeless. I had somebody tell me, I'm going to donate a bunch of books. I said, books are great. Kids got to read. I said, I agree. They go, you don't seem that excited. And I go, I'm very excited for the kids that can read. But I said, the problem I have is 2,000 kids are homeless. And the last thing on their mind is reading, finding a place to stay. Where are you going to sleep? So those are things that we have to get at. And I think until we change that poverty cycle, I think we're going to continue to have a lot more ACEs as time goes by. It's just, it's so ingrained, and then it becomes generational. And then how do you unwind that? But technology-wise, I haven't found anything really on the cutting edge to go after that, other than, I think you could probably track them. That would be about it at this point. But that's not going to help you get at it. Really getting after poverty, I think. And providing better access to care. Access to care, that we can do with technology. We have lots of angles for that. Great question.
Are there any questions in the chat, Angie?
Nope, no one has any questions.
Well, I will ask a question. I don't know why everybody's shy. Very nice talk, by the way. I'm wondering, when did you become comfortable talking about the disparities, especially when it comes to race and ethnicity?
I'm not. But we have to. Unless we start actually asking the tough questions, being willing to listen to people answer in a way that is straightforward and truthful, we're not going to be able to address any issues. And so we have these conversations pretty regularly at our hospital. And it makes people very, very uncomfortable. And I'm okay being uncomfortable. You know why? Because again, it's the only way we're going to change things. I don't understand it. We had a lot of pushback when we started doing implicit bias training. We had, Black Lives Matter signs up everywhere, and some of our staff felt like we were discriminating against first responders, law enforcement. And I tried to make a point. I said, if you go around the halls of our hospital, you see thin blue line, thin blue line. You see a lot of support around our hospital for first responders, as we should have. They're fabulous. They do a great job. But if you can see that, how come you can't see Black lives? And it was offensive to some of the people. And I said, why is it offensive? Because they're denigrating police. And I go, denigrating police? So, it's attitudinal, right? Being able to have those conversations is something we have to do as a community, as a country. If we don't do it now, you can see what's happening. It's going to split two countries eventually, I'm sure. Maybe we need to. That's a really, really insightful question. Thank you for asking.
Pay equity that you brought up. How is that the East Coast universities are doing it very well? Because recently I was in the East Coast and this got brought up like a sales point. That, how is pay equity in your institution? I have to tell them, to be honest, transparent here. So are you making it transparent to get there?
So that's another challenge. It's a different generation. When I started, nobody knew how much money I made. I wouldn't want to get paid it now, I can tell you that, because it wasn't very much. But the new generation, they tell each other, this isn't fair. You know, I have some of my junior faculty who came and talked to me about it. So we actually set up an approach. It's not my money, it's our money. And so we invest it based on sort of our collective interests as an academic pediatric center. And so, you know, if you're doing the same job, you should get paid the same amount of money. We're pretty close. And, you know, I think of this in terms of biological equity. Because women generally, it's women that are the child care providers. I consider myself a child because I know my wife this afternoon. But there's a sacrifice that's made academic. Why should we have some of our community being penalized for doing something that we advocate, right? We're all about patients and families first. Yet, you know, it's not. So that's crazy. Can't stand for it, right? You have to be intentional. It has to be done. So probably one of the funnest days of my life was walking into more seasoned female faculty's office and apologizing to her and giving her a $40,000 a year rate. She was crying. I was almost crying too. But I mean, those are things that matter. We can take care of one another because our jobs are hard enough as it is. Impactful, impacted by our community that we live in, wherever that is. There's always poverty somewhere. But how do we actually approach this as a collective group? Well, first of all, we got to get comfortable talking about it. We're not talking about it. Of course.
That was at the top. Where do we sit compared to them, say, in a position?
That's sorry. So it depends. Well, I don't know the answer to that, but it would depend on the system that they have, because some of the countries in Europe have a public system and a private system. So they have a standard pay for their public, and then they do private medicine afterwards for profit. You see the same thing in South America. So on equity, no idea. I can tell you in Canada, it's a little higher salary for most faculty, but you don't have the robust sort of business laws that you can actually invest in. So it's harder for you to actually living there if you're paying regular taxes, unless you have the ability to incorporate. So they just started to do that for Canadian physicians, and they're actually doing better now. They got paid more than they took home. So what is the burden of physician pay? So it's actually minuscule compared to most of the other drivers of healthcare costs. As a matter of fact, what do you think the highest and most rapidly cost point is in healthcare? Administration. Yep. And there's actually a graph out there. That's a good question. I'll get it and put it in this talk. There's a graph out there that looks after physician pay, administration pay, physician recruitment, and administrator recruitment. It's fascinating when you look at it. Right? And who controls the money? Healthcare. Not the patients, not the docs, not the nurses, insurance companies. Mostly. Yeah. It's a perverse system we need to really, I think, retool it. Get called a hair check if you do that. No, that's a great question too. Thanks. Yeah, no. Not anymore.
Any other questions for Dr. Brophy? Thank you for that thoughtful and provocative discussion, as always with you. And I appreciate sharing that.
Thank you guys.
Open your eyes.
Appreciate it.
Thank you. Stay for our next. Yes. gonna talk about. Something I'm short.
If you have to leave now, there is dessert, but you have to go.
Yes, the dessert is in the poster rooms, so. And Lesta, maybe if you wanna come up and help me. All right. So first of all, I just want to really thank everybody for coming and supporting the Peds Research and Scholarship Day. And especially to everybody who actually nominated and lifted up their colleagues. You know, in this time right now when there's a lot of, worry and anxiety about medicine, and it's just so important to help lift up your colleagues and encourage them. And so I'm extremely thankful for everybody who nominated some of our faculty. It just makes a world of difference to read the amazing comments. I know what everyone does, but sharing that with the rest of the group just means the world to me and to them. So thank you. I also really want to thank the awards committee and the abstract graders this year. So this is our amazing people. So Kevin Francis, LJ Plaz, Bill Waltz, Nicole Pobinga, Maria Barber, who just snuck out. Oh, there you are, Maria. Thank you. Kelly and Angie, of course, for all that they've done to make this day. And then Christy Hockett, Connie Taylor, Woken Olgan, Thane Muntz, Lesta, and myself. So thank you to them. And first and foremost, the biggest thank you for our T. Denny Sanford Distinguished Lecturer, Dr. Pat Brophy. So thank you.
I had hair then.
We're so grateful for you coming. It's been wonderful to see you again.
Thank
So,
you guys.
yeah, thank you.
It's been nice to meet you.
I also want to do a shout out and a congratulations to all of our faculty that were promoted this year. So congratulations, Larry Meyer, Ashley Sandine, and Mike Coretta. Promoted within the academic track to associate professor. So I'm super proud of you guys. Also, congratulations, Larry Meyer, who is the recipient this year of the big USD, not just our departments, class of 1954, not that he's that old, this is the class award, the Warren Jones MD Faculty Award for Teaching and Research. Larry, can you stand up and be recognized? Any of you who know all the work that Larry has put into teaching and research and investment in students all know he's well deserving. And then also Michelle Schemmelfennig, who also is the 2022 USD School of Medicine Class of 1983 Clinical Faculty Award. I know she can't be here, but let's all give a big round of applause to Michelle. They received their awards during graduation. Also, we had our Excellence in Pediatrics Award, and this year's recipient was Benji Wiletsko. So Benji was one of our medical students on the Rapid City campus, and he was nominated by Dr. Simmons. We're super proud of Benji. He received his award and will receive his stipend, but he actually graduated May 6th and is transitioning to Johns Hopkins and All Children's Hospital in St. Petersburg. So we're super proud of Benji, and he's grateful for the award. So I also want to thank, in the boxes there, Lesta, our chief residents. So if you could please come forward, Annie, Martino, and Jade Arabos, and then Amelia couldn't be here, but I am so proud of you. Amelia is going to be a general pediatrician at Essentia Health, and Annie will be transitioning to a neonatology fellowship in Peoria, Illinois, and Jade is going to be working back in Florida in the sunshine. So let's thank them for all their hard work this year. So the other thing, so now we're going to move on to our PEDS Department Faculty Awards.
And first of all, our Master Clinician Award category, we had so many wonderful nominees this year. Dr. Kelly Sweet, who is one of our, actually, she's a locum tenens pediatric neurologist that comes to Sanford, and she's been coming for years, and she is an amazing resource for our students, but also is just an amazing clinician. And so Biba Steinberg-Kara nominated her, and you can read what she said about her. But I thought her comments were true in that she always provides support and understanding, even in the most difficult neurological situations for kids. She's fabulous with families and with even teaching the faculty. Dr. Christiane Maroon was nominated by Dr. Koima, who I saw, he's here. Oh, there he is. Thanks, Rick. You lifted up your colleagues. I was so thankful for that. Thank you. So those of you that don't know Dr. Maroon, she has been practicing in our state, I think in Mitchell originally, right, Rick? Yeah. Oh, where is she? Oh, Christiane. So we're so thankful. She is like a huge resource for the rural care of kids, but now in Sioux Falls at Avera, and is just an amazing resource. So you can see what Dr. Koima said about her. She's sought out by parents with children who have complicated medical needs because she has deep knowledge and she has multiple in every area of pediatrics. I know, having worked out in the middle of the state, you have to know everything about children, and we're so grateful for her. Dr. Lesta Whalen, she was nominated by Gokhan Olgan, and he wrote that she has been exemplary in implementation of an extremely successful ECMO program at Sanford Children's Hospital, which has been a great asset this year because of ECMO for COVID and all kinds of things. And so we're so grateful that Lesta has implemented that all across our state. We have that service for our state. And then Jennifer Reed, you can see, was nominated by Dr. Carl Galloway as an outstanding physician who is constantly reviewing literature to improve her patient care. She's a model of compassionate care with a willingness to spend as much time as needed with any patient or family. So everybody who was nominated, please stand, because I just want to recognize all the amazing work that you've done. And then Gokhan, I see you sneaking in. Could you come up, please? Yes. No. Gokhan is going to be giving our recipient of this year's award, our Master Clinician. Oh.
Hi, everyone. So, as you all know, we have a very successful ECMO program in this hospital. And actually, we are the only ECMO program in the state of South Dakota. And since its start, we have provided VA and VV ECMO to not only children, but also adults as well. Our survival rates are comparable to the centers of excellence. And of course, this just didn't happen on its own. Dr. Whalen's mission was to establish an ECMO program here. And well, yeah, she did it. And at first, firsthand, I observed the challenge of starting a complicated and labor-intensive program. To be honest, there were many hurdles, but she had to train too many people, ECMO coordinators, and she set up orders, set guidelines, you name it. And there were some skepticals, but at the end of the day, I've observed that she just did not just create a program, she just built a culture here. Now she's taking it to the next level and training adult nurses just to help create successful adult ECMO program. And in addition to all, she's a great physician, colleague, and a friend. And she's the mother of two wonderful children. And I proudly announce Dr. Whalen as the recipient of this year's Master Clinician.
I'm hoping to get pictures here in a minute. Next is our Dedicated Teacher Award. So two nominees for this, Dr. Carl Galloway nominated, and Jessica White nominated Dr. Jessica Olcott. And she was nominated because she's so very involved in making us better physicians, striking a balance between autonomy and supervision, encouraging the resident and medical students to make decisions as if she is the primary physician, yet with a steady presence to guide and facilitate conversations. And Jessica wrote that on behalf of the residents. She's also been instrumental in modifying the curriculum with the goal of improving education experience for students across all campuses. And the second nominee was Dr. Sam Schimmelpfennig, who was also nominated by Dr. Koima. He has served as a valuable resource to students as they acquire knowledge of a broad range of pediatric subjects, but particularly of sports medicine and orthopedics. He does this teaching in such a way that students can easily see how they will incorporate topics into their practice. And I can tell you, working with Sam on the graduate medical education committee and with Jessica, these are amazing teachers and really do care about our students. So please acknowledge both of them. I know neither one are here.
I'm online though.
What's that?
Jessica Olcott is online though.
Oh, and Jessica, you're the winner of this year's award. So congratulations, Jessica.
Thank you.
And we have
Thank you.
your award here when you come to visit the office.
Sounds good. Thank you all so very much.
Next is our Kindness Initiative Award, and we had 2 nominees for this category. Again, Dr. White nominated Dr. Carrie Kippis on behalf of the pediatric residents. Dr. Kippis, it was nominated because she's a gentle soul, both with learners and most importantly with her patients. And I wish that there were more individuals like her because of the good that she does for her patients and her colleagues. And then Dr. Katie Anderson was nominated because she exudes kindness. She's a positive and uplifting in everything that she does. She recognizes the positive aspects in everyone. Some people have kindness in their blood. Dr. Anderson is one of those people. And I would like to have both of you stand because you're just both, I agree, kind, and you put kindness into action. So thank you for that. And so you're aware this is a new award this year because I think sometimes kindness is one of the best medicines. So I'm so super thankful for that. So this year's award winner will be Dr. Kippis. If you could come up. Jessica, do you want to say anything on behalf of the residents or Jade or Annie? You want to say something? Oh.
So if you know Dr. Kippis's clinic, it can be very long. She spends a lot of time with her patients, but I think one of the biggest things with her is she always makes sure her residents have a stool. We always stand, and it's so ridiculous, but we always stand in most of our exams with all of our patients, and she always makes sure that all her residents are comfortable. She always asks about your personal life, making sure you're good at your home life with work-life balance. And so on behalf of the residents, we really wanted to nominate you for this.
We love that story about that. You always make sure they have a stool. And then our last award is the Distinguished Researcher or Scholar Award. There were 2 nominees, Dr. Larry Meyer, he's popular this year, who was nominated because he's an active and energetic member, engaging in teaching and scholarly activity through mentoring of medical students in manuscript preparation. He's dedicated to education, research, scholarly pursuits, teaching, and service is admirable. He was nominated by Dr. Reuter. And then Dr. Alexei Savinov, he was nominated because he has an established track record for investigating the mechanisms of autoimmunity leading to type 1 diabetes. He's a valued partner in several consortia-based projects to adapt cognate antigen receptor T-cell approaches to treatment or preservation of beta cell function in type 1 diabetes. And he's leading the immunological validation of a novel anti-thymocyte globulin to help preserve insulin production after diagnosis. Dr. Griffin has been impressed repeatedly by his care and compassion with which he guides students in successful completion of projects. And is Dr. Griffin here? I gave it away. So this year's winner is Alexei Savinov. So Dr. Savinov. Thank you. And last but not least, I want to recognize our amazing posters. So we had a lot of amazing posters submitted this year, or abstracts submitted. This year we offered free poster printing service, which I thought was nice. I don't know if everyone used it, but it was great. And we actually have multiple awards, and thank you to our abstract graders for this. We used a objective rubric to actually score all of the abstracts in multiple categories. And so first we're going to do best abstracts in the clinical and QI and case study projects. This year's best QI project goes to Dr. Stephen Messier. Is he here? He's in the NICU, and I know they're having a crazy day. But for his abstract, ensuring NICU infant Tdap immunization. And so congratulations to Dr. Messier, the whole NICU team that participated in that QI project. Next, we have base clinical and translational research for her work on placental lipid processing in the setting of diet-controlled gestational diabetes. And I can say because Becca was working in my lab, but she did an amazing job of getting a project done in just 3 weeks, counting her vacation. So congratulations on your best abstract for basic, or for best translational research. And then best case studies. This year's best case study goes to Dallas Soyland and team for their case presentation on primary epidural sporadic Burkitt lymphoma in a 3-year-old, a case report and literature. And he was mentored by both Kay Wagner and Sean Vaughn. So Dallas, congratulations. Yes, and Megan. Oh, congratulations, Megan.
Again, he just.
Oh, Steve, come, we just announced you, Steve. Come on up, and congratulations, Steve, on best QI. Steve, what was your rate of immunization increase with our QI project? Oh. Oh, good. Hooray. Congratulations. Thanks. Hopping over. And then now we have 2 basic science abstracts. So Dr. Chandrasekhar, if you want to come up and present the 2 basic science awards. First is our best basic research award by an undergraduate. You want to, or you can. Okay. So our best basic research by an undergraduate or graduate student this year goes to Bethany Friel. So Bethany's work in the Francis Lab has been instrumental, along with the Francis Lab, including many of her colleagues, which are here, including Ellie, who's definitely going into PTA. But on cholesterol dysregulation, which disrupts astrocyte function through astrocyte microglia crosstalk. So congratulations, Bethany, and we know you're going to be successful as you graduate this next year. The next category is the best basic research for someone who's passed their training, so fellow, junior faculty, or a research associate. And this year's recipient of the best abstract is Dr. Carla Otterpool, whose work in the Chandrasekhar lab looked at thick ascending limb specific inactivation of myosin 9 and 10 results in progressive kidney disease with sexually dysmorphic sodium transport regulation. So congratulations on all your work in that slide. I hope that you'll all just take a few minutes to visit our posters. We have our clinical and translational QI posters that are going to be, they're over in this room on the right, and then the all of the basic science ones are on the left, so that you can look through all of them. But there's desserts in each of those rooms. So thank you all for coming and lifting up each other, and keep doing the amazing work that you're doing.